Get ready. 3, 2, 1 and start. A number of announcements have been made by the central and state governments on their intent to offer universal health care. These welcome developments are timely as India is now rapidly becoming one of the few countries that do not seem to have a concrete plan for UHC in place. Even poorer countries such as Ghana, Kyrgyzstan, Rwanda, and Vietnam have now started to make significant progress in this area. Paragraph change. A fact often overlooked in these discussions, however, is that UHC is a complex idea and contains several prerequisites that need to be carefully incorporated into its conceptualization, design, and implementation. This article attempts to outline 4 of these essential elements. The first and perhaps the most important element is the need to distinguish UHC from universally available health insurance. UHC seeks to ensure financial protection with the provision of appropriately priced, high quality and integrated healthcare (combining primary, secondary and tertiary care into a single patient-centered healthcare system. Ideally, financial protection and comprehensive healthcare are bundled together into an integrated managed care proposition where the financial protector or the risk manager and the provider are a single entity. One of the key benefits of this model is the significant shift in incentives for the health provider from the current focus on promoting hospitalization and needless care procedures to incentives for promoting health and prevention of illness. Since the provider receives only a fixed amount per year irrespective of the actual treatment provided, managed care places rational treatment and cost effectiveness at the center of the model. Because of their very nature, healthcare systems owned and financed by ministries of health are ideally suited for offering this type of managed care. And if, but only if, there is very strong confidence in the ability of the system to regulate and monitor both patient and provider behaviors as well as population level outcomes, it is possible, as Thailand has done successfully, to invite large non-government players to also bid to provide such managed care services. And while the regulatory challenge in outsourcing managed care to the private sector is quite considerable, it is very clear that fragmented health systems with different providers taking care of different parts of the health system, such as the private sector providing hospital-based care and the government focusing on primary care with patients free to bypass, it is the worst of all possible choices. This fragmentation is the principal reason why a country like the United States finds itself in a situation where insurance premiums and costs of healthcare are both rising rapidly but population level health indicators are well below those of other comparable countries. The second element is the need to shift the focus of attention from hospital based care to primary care in terms of financing development of infrastructure and usage. In order for India to achieve UHC both in terms of goals, it is clear that fewer than 2.50% of the patients in any given year should need hospital based care. This implies that 97.5% of all conditions would need to be dealt with at the primary care level. UHC would therefore need substantial investments at the primary level combined with a strong gatekeeping framework that does not allow patients to seek hospital based care unless they have been referred by a primary care provider. It is believed that over 95% of patients who visit tertiary care facilities such as JIPMER in Puducherry and AIMS in Delhi are at the wrong place and have incurred all the hardship and costs that they did needlessly when they could easily have been cared for locally if good primary care was available. Evidence from Andhra Pradesh also shows that under Arogyashri, people are overwhelmingly seeking care at hospitals even for conditions which are patently treatable at primary care facilities. When India undoubtedly needs additional hospital beds to provide adequate coverage even at the 2.50% level mentioned earlier, it is imperative that the focus of immediate attention should not be hospitals or more aims like centers but well designed and capable primary care facilities so that patients can go there directly. Should they inadvertently end up at hospitals for seeking such care, they must be directed back. Only this combination of improved availability and mandatory gatekeeping will start to reduce the excess demand for hospital beds even as we gradually seek to address the unmet needs for hospital beds in deficient regions. Full stop. Thank you.